My name is Colin Standfield. I live at 20 Balfour Avenue, Hamwell, W7. My current role as an unemployed person is a fairly full-time activist on behalf of the hospitals in northwest London.
Could I ask you please to have a look at volume 3, and it's at page 1093. Should I hope be your submission?
That's very much like it, yes.
Can you confirm that it's true to the best of your knowledge and understanding and that you wish it to stand as your evidence to the Commission?
It is true, but it's now 3 months out of date. I have brought a couple of the slides updated to the figures which were published on Friday of last week, if that would be helpful.
Could you first of all explain, in brief terms, what it is that you have been monitoring over the past 2 years?
I've been monitoring certainly over the past year's worth of data, the attendances at A&Es and type 3 emergency facilities, the waiting times for type 1 and for all attendances. And I'm starting to do the same for admissions from those departments.
Now, as I understand your submission, it consists of a slide form presentation that was made to, I think, the People's Inquiry. Is that correct?
That's correct.
Can we just go through some of the key features of it, please?
Mm-hmm.
So first of all, what is it that you say about the closures of Hammersmith Hospital and Central Middlesex Hospitals, A&E? What do you say about that being necessary or not on the grounds of clinical safety?
The story we were told was that it was on the grounds of clinical safety. The Shaping a Healthier Future had spent months and £4 million on the McKinsey organisation coming up with the proposals in a pre-consultation business case which ran to 1,156 pages and a decision-making business case that ran to over 2,000 pages, and the independent reconfiguration and Don't Rock the Boat panel came along in a couple of weeks and said, we think that these two hospitals may be unsafe. And it struck me as slightly unusual that after all the years that the same people were working on behalf of the community and developing the hospitals, that they should come up with a plan that said over 5 years we might wish to close 4 A&Es. These people came along and said we'd better do it now. And I think that's what they wanted to do, and I think they took their cue from the Scottish play and said if 'twere done when 'tis done, then 'twere well it were done quickly, if the assassination should come up.
After the Shakespearean, can I ask you to just pause a little bit and move forward, because I'm not sure people are getting your voice. You see the microphone in front of you. If you
pushed it away.
Thank
right.
you. I wouldn't want people to miss more Shakespeare.
That's all the Shakespeare I've got today.
Now, moving on from that, what is it that you say about the clinical safety of those organisations? Are you able to comment on that?
I'm not clinically competent to answer that. What I do know is that we should have been assured that the hospitals were safe. I think what happened was that the Shaping a Healthy Future team took advantage of the fact that the IRP had put this in more as a footnote than anything else, and decided to close it. And when I asked Dr. Spencer, the medical director for Shaping a Healthy Future, why that should be, given that there have been numerous assertions and reassurances that nothing would happen in terms of closing A&Es until all of the work in the community was in place, and I cite a number of those in my document. He said to me, we were advised to close the A&E department at CMH and the emergency unit at Hammersmith earlier than we had originally planned. So that meant that it was done in a hasty, unplanned fashion. And he said that it was too early to see the extent of reductions caused by improved community and primary care, which are still in their early stages. So everything we were told about replacing A&Es with this wealth of community and out-of-hospital care did not happen when it came to the closures of those two hospitals. I think they were done in haste because it suited their programme, and they had this independent reconfiguration panel footnote to say that that's something you should do.
Did he indicate where the advice came from?
He did not. He said we were advised.
And were you able to elucidate anything further?
No. My correspondence with Dr. Spencer is sporadic and mostly one-sided, I'm afraid.
Now, you also talk about funding and investment in out-of-hospital services, and you discuss a figure of 190 million. Can you help the Commission with where that comes from and what it is that you say those funds will be available for?
The figure moved from 120 million in the pre-consultation business case. Dr. Spencer told the Ealing Gazette it was 138 million over 3 years. We had a figure of 120 million in a summary of the business case. And then suddenly in the decision-making business case it had grown to 190 million. So I made some inquiries of the team and of Dr. Spencer where this 190 million came from, because it kept being represented in different forms. It was a cumulative, it was a recurrent, and so on. And after a series of emails, I got to the very helpful and very clear statement: the out-of-hospital services investment will have accumulated to a recurrent 190 million by 17-18. This means that each year new money will be invested. The total invested will increase, and by 2017-18 we will be spending 190 million more on out-of-hospital services each year compared with now. And I hope you followed that, because I can't understand that. But that's what they were planning to spend. Now that is an awful lot of people, if most of that is going on staff. Looking at the HSCIC data, the average...
Pause there, could you just state the acronym, the name rather than the acronym?
Sorry, I'll go back a page. It will be the Health and Social Care Information Centre.
Thank you very much.
The average salary in the NHS is 30,846. If you add on something like 22% for on costs, an average person will cost you 37,000. Now, 190 million pounds would buy you 5,048 of those, which would mean if, for example, they all went in North West London into doctor surgeries, there would be 11 extra staff in every single surgery. Now, I haven't seen that. If some of them were in the community, you'd have 3 or 4 extra staff in a GP surgery, and a load of people in the community somewhere in a building running something. But I have seen none of that, because I think that figure was a pure fiction. They wanted to have a figure in there to reassure people that they were doing something in the community when they were closing hospitals. And they obviously couldn't put in a figure with 10 digits, because £1 billion is what they were expected to save from the budget. They couldn't put in a figure below 100 million, because how on earth could you replace 4 A&Es with a figure of £80 million? So I think they invented 120 from nowhere, and it crept up to 138, it crept up to 190, and nobody has explained where that will come from. If you look at the business cases for the individual CCGs, you'll see figures of around, it's always 18 to 21 million for this, but no one has specified what this will go on, other than mostly on staff. Now, I don't think that is a basis for closing 4 hospitals, because they have no idea what these new services will be. And I'm not aware of anything that's happened in my part of Ealing. I'm aware of some pilots and trials and services. There's an operation called STARS running in Brent, which works in the community, but I have no idea where they would spend 190 million. I don't think they could get the money away. But that's the figure they've given us.
Now, moving on. Thinking about accident and emergency attendances in North West London, are you able to help from your documentation and your updates whether those are rising or decreasing or have remained static?
I would say they bobbled along. There's nothing in the original NHS Act that said that patients had to line up in an orderly fashion and book their attendances, so there was a smooth curve of attendances. So naturally they'll go up and down. But the general trend is around the average. There was a slight rise just before Christmas of last year. There was a slight rise in June and August. But generally speaking, the charts simply show that the attendances bobble along up and down, and it's the same as in the document. I wouldn't say there was any great change, and certainly for Ealing and Norfolk Park, it's more or less a flat line. So the attendances are not the problem.
And what do you draw from that then in terms of the attendances? What relevance do they have?
I draw from that the fact that where you have more or less stable or cyclic and seasonal attendances, you should not have a massive drop-off in performance after September of last year, when 2 A&Es were closed. Now, the drop-off happened nationally and across London as a whole, but it happened an awful lot worse in North West London, and massively worse in Ealing and Norfolk Park. And of course, Norfolk Park bore the brunt of the closure of Central Middlesex.
And are you able to help us with up-to-date figures about whether that is still the case or not?
It is still the case. It is still the case that Ealing and North West London languish a long way below the London average, and they languish much further below obviously the average for London when you take North West London out, and they're well below the England average for type 1 weights to the 15th of March 2015.
I want to ask you now about... please do go on.
And that is with the inclusion from the 12th, I think, of December of the new A&E unit at Northwick Park, which is no bigger than the old unit at Northwick Park. It has exactly the same number of beds.
And can you help us with how many beds that is?
I think it's 20 beds, but I'll need to check.
And are you able to say definitively that that's the same amount of number of beds?
It is the same number of beds. It's been reported in the Brent and Kilburn Gazette, I think. I'm fairly certain it's the same number of beds, but they're saying that they work in a different way. And this is always the case, that you say that there aren't as many of these, and people say, but it'll be working better because something else will apply. And I don't know what it is that's supposed to apply, but I do know that in the week after the new unit opened, it recorded its worst ever A&E performance. Now, that may be teething troubles, but I don't believe in health service you should ever use the excuse of teething problems.
Now, I want to ask you about ambulance waiting times, please. You seem to suggest that there is a failure in ambulance waiting times at the moment. Is that part of a London-wide phenomenon, or is something else going on? Is it particular to this area?
There is certainly a London-wide shortage of paramedics, and they are being currently recruited mostly in Australia and New Zealand. There is a problem which is difficult to pin down because I don't have access to the data, but it is known that ambulances are waiting on ramps more than they used to be. Now, an ambulance waiting on a ramp means that 3 patients are waiting. There's one in A&E waiting, there's one on the ramp waiting, and there's one waiting for the ambulance that's on the ramp to get to them. They are in short supply, and the ambulance service in London, LAS, are acutely aware of the problems of recruitment and availability of ambulances. And having A&Es that are backing up is not helping that. It's a perfect storm that ambulances are taking people in. And of course at Northwick Park, with their new A&E, since November, the month before the new A&E started, they've been doing a postcode allocation of patients coming in. So if you're in Northwest 6 or Northwest 10, the ambulances won't take you to Northwick Park. They're told to take you to St Mary's. Ambulances are required to ring in advance to Northwick Park before they bring anybody in. There are doctors in South Brent who are being told not to refer patients to Northwick Park. They are shipping out patients who desperately need beds to Mount Vernon Hospital and Willesden Community Hospital because they don't have the bed capacity in Northwick Park. And having cut beds as a result of Shaping a Healthy Future, they're now desperately putting them back. They've put 48 in, and there are some...
Pause there, they put 48 beds in where, please?
Somewhere in Northwick Park to take people. But I was simply given a list of beds, 10 in December, 10 more in January, and it'll be 48 sometime soon. And some new portable units will deliver another 50 beds, I think it is, sometime later this year.
So can I just check that I've understood your evidence correctly, which is that beds which have been taken out as part of the SHAF programme have now been reinstated, is that correct?
They are now desperately reinstating beds in Northwick Park.
Now, one of the other things you talk about, it may be that this is linked, you talk about cancellations in elective surgery, and you seem to draw a causal link between that and the closures of accident and emergency units. Can you explain your reasoning around this, please?
Yes, if the accident and emergency units close and put pressure on the remaining services, which is my thesis, I think I have the evidence for it, graphically I do, that means that people are increasingly filling up A&Es, and within the 4-hour waiting time, particularly for type 1s, the more serious cases, they are struggling to do anything with them in the 4 hours because of the numbers going in rather than the quality of what's there to receive them. And so the 4-hour is for discharge or for treatment or for admission, and what they always do is admit when they come close to the 4 hours. Now, it's known on data running up to August last year that 51% of admissions from type 1 A&Es occurred in the last hour, and of those 44% were in the last 10 minutes. So that is what happens. In A&E, when you get crowded, you try to admit. Now, if you haven't got beds to admit people to, you end up with the pressure on beds. And so what happens then is that in the evening of the day before a planned operation, a group of people will sit down and decide to cancel them. Now, hospitals are not supposed to cancel elective operations, certainly not on the day, which is why the meeting is held the evening before, so it's on the day before, so it's an operation cancelled in advance, technically. Not that the patient would recognise that. So after the closure of the A&Es, I was hearing stories of operations being cancelled at Ealing, anecdotally. So I asked Dr. Spencer in an email why this should be, because an email had gone around saying there is great pressure on beds and services, so please will everyone get people discharged as quickly as possible. And he said to me that this was having no effect on planned operations. So I asked under Freedom of Information for planned operation cancellations for that week, which was I think the 19th, and the following week the 26th of September. And there was a total of 29 operations, planned operations cancelled for lack of beds. Now, in the first quarter of this financial year, Ealing cancelled 22 operations for all causes for the whole quarter. So in 2 weeks, they had cancelled as many as they cancelled for all causes in the first quarter. I then asked, because I thought I needed to get this for the whole North West London, I put a Freedom of Information request in on the 11th of November to all of the trust to ask for their planned operation cancellations from a period covering September and October and November, and up to the early November, the date of writing. And as usual with FOI requests at North West London, nothing happened for 20 days, and what came back was a mishmash of disparate data. But what I can say, in the interim, having had a letter from the Deputy Chief Executive at Norfolk Park, that 29 figure for 2 weeks in September came down in his letter to 13 for the whole month. And in my FOI request in November, it came down to 6 for the whole month. And I've not been given an answer as to why the planned operation cancellations should have been, I would say, massaged downwards, because that is an indication of the A&E pressure. And I cannot tell you what the planned operation cancellations are across London because the data are so badly presented. I can't trust them.
Can I ask you, just very briefly now, what in your view are the risks, if any, if current proposals for SAF globally continue to be rolled out?
Well, having seen half of it, I would say it'll be twice as bad as it is now. If Norfolk Park can plunge to a level of 51% of type 1 A&E seen within 4 hours on one day, the 16th of February, then that means that the whole system is under pressure. It may not be only as a result of the 2 closures, but I don't know what else can be responsible for that significant effect. Given that, certainly in North West London, certainly in Ealing and Norfolk Park, the number of attendances is not the problem. There is no sudden rush. There is no increase in acuity, which is the latest spin that they're putting on it, that people are sicker when they come in. Well, the only ones who are sicker are the ones who've had to wait longer for an ambulance. But there is no, they're looking desperately for some reason for explaining why it is that people are staying longer in A&E and are being admitted. And they're saying, oh, a rise in acuity. No data for that at all. But that's what they're saying.
And just thinking on the other side of the coin, if the proposals are rolled out, what if any positives are there from that?
Well, none that I can see. I've heard you discussing this idea of centralising. Centralising care, specialist care, in larger units works for a very small number of conditions. It works, obviously, for burns, it works for major trauma. I tend to disagree over stroke because the development of hyperacute stroke units went along with an increase in more widespread availability of thrombolysis or clot-busting drugs. And I would say rather than flog all the way to a hyperacute stroke unit, you're much better off getting a paramedic to administer thrombolysis, which can be done under NICE and under NHS guidance. But, okay, I'll take the position that everyone else seems to take, that having hyperacute centralised stroke units has helped. I think it's a marginal thing. And obviously, the trauma and the burns help. But for everything else, and it's about 96% of cases, it is not worth passing even a mediocre A&E to get to a specialist unit with all the bells and whistles. Most A&Es are perfectly good. I don't actually want, I have to say, a world-class A&E at Ealing Hospital. I want a competent, London-class, Hanwell-class A&E at Ealing Hospital, and I think all hospitals should do that. And if all hospitals did that, you wouldn't need to pass them, and you certainly would not want to pass them for conditions that are not better treated at these super hospitals. Conditions like anaphylactic shock, cardiac arrest, asthma, choking, drowning, hanging, all sorts of conditions are much better treated at a wide availability of good district general hospitals, and you don't need this centralisation. Centralisation means people are travelling longer, and we know from evidence submitted by Professor Nichols from Leeds that leads to worse outcomes.
Thank you. If you'd like to wait there may be some questions from the commissioners.
Thank you very much. Two questions. Firstly, in relation to your point about wanting a competent, essentially local A&E hospital, is that to be geared numerically to population or some other criteria? That's the first question.
Generally speaking, they are, and at the moment, the boroughs in North West London are on the England average for population per hospital. If they take 4 out, we'll be up to something like 250,000 per hospital from something like 180,000 now. And it seems to be somewhere around the 200,000 level. But you can argue the case in a number of different ways. You could say you could manage a 500,000 population, and then you'd need to know what else you need to build in. But it seems to be about 200,000 per hospital is reasonable.
Yes, just a supplementary to that. Is the figure, in fact, dependent to some extent on the demography? In other words, the nature of the population being served. You could have a much smaller population needing an A&E than a bigger one.
I doubt that the differences would be substantial. You would be predicating a huge population of people over the age of 70 or 80, or a huge population of very sick people. Now, we do have pockets, and I did hear somebody talking about TB.
There's a pocket here, possibly.
There is a pocket. There are parts of Ealing which would rank in the top 22 countries in the world for TB incidents. So yes, TB is a massive problem in parts of Ealing.
All right. The second question is something quite different. Having spent, as you put it, or at least in part of the summary of your submission, 2 years or more monitoring the reform proposals, I want to stand back for a minute and ask you this question. If you can't answer it, please say so. And that is, on reflection, do you think, in fact, something needed to be done or not? If you follow the question.
I do follow the question. I think that something needed to be done if the data were correct about the problems that they had. Now, I don't trust all of the data that they produce. If there is a problem with lack of consultant cover, then you do what Nye Bevan said and stuff their mouth with gold to make sure that you had consultant cover. Now, if Agenda for Change or some other bureaucratic structure prevents you from paying bonuses to A&E surgeons or radiographers or whatever it might be that you're short of, then that's something you need to overcome. That is a management issue. The whole problem in North West London that was summarised in great length in the 2 volumes of the business case is a management issue, and it should not have devolved to, well, the easy way out of this is to take all of the consultants and divide them into a smaller number of hospitals, job done. That is not how you do it. We know that those things are wrong. We know that it doesn't work when you start trying to plan for recruitments of people. It happened with nurses. They said, we won't need so many nurses, and they stopped recruiting nurses. Now they've got a nurse shortage. So you don't do it that way. You say, what do we need to have in this hospital? We need to have a rota which has 7 A&E consultants, or 9 or 11 or whatever it might be, to cover the hours of daylight and the weekends. And that's what you do. What you don't do is say, we seem to be running short of consultants over the last few months, let's close a hospital and shove everyone over there. Because the problems you then get are much, much worse than having a consultant on the end of a telephone. So I think something needed to be done if the problems were as they hinted, but they never give data on what the problems are.
All right, thank you very much.
Colin, you have been following this for a long time, I know. And of course it began before the CCGs were formed. It began under the so-called NHS North West London, the grouping of PCTs.
It did.
And it's now they call themselves the North West London Collaboration of CCGs. with some involvement. Dr. Mark Spencer is now actually part of NHS England, London area team, so there's kind of a bridge over to...
It's part of the furniture.
Well, yes, that's one way of looking at it. I was just thinking, and they have produced these enormous volumes of apparently now completely superseded business cases. But I seem to remember at one point identified why it was that nobody on the boards of these various bodies and collaborations actually read the whole of the business case. Can you remember what that example was? There was an example that you gave.
It was at the meeting of the Joint Committee of the Primary Care Trusts in February 2013, when they were debating the decision-making business case, and I asked all of them to put their hand up if they'd read all of it. And nobody did. And subsequently I was told, well, you were just conducting a straw poll and no one was interested in playing. Now, I think they didn't put their hand up either because they hadn't read it or because they probably thought I'd have a follow-up question which would have put them on the spot. But I'd read it, tedious though it is, and chaotic though it is in its pagination. But I wanted to see what was in it, and what I found in it was a number of inconsistencies and a number of lies. And the egregious lie, which occurs 6 times in the decision-making business case, is national evidence demonstrates that home birth is safe and recommended. And I looked everywhere for any document that suggested that home birth was safe and recommended. Home birth is safe where it's safe. Home birth is safe for a woman who's had children before, who has no pre-existing conditions, and who has, according to the Royal College of Obstetrics and Gynecology, rapid access to obstetrics if needed. Now, to say that home birth is safe and recommended and there is evidence for it was a lie, and I challenged them and they did not come up with any evidence except a number of people saying it's awfully good to have home birth as an option, which it is. And that was the sort of thing that was going into the decision-making business case. Lots of asseverations about what was going on, but no fact, no data, no research cited. And it happened in the foreword to the consultation document where they said, we believe that more care in the community produces better outcomes. Not a shred of evidence was cited. And I think if you look through my submission, I haven't actually attributed all the graphs to the Unified 2 data set that comes from the NHS, but everything I say comes with an acknowledgement of the source. Now, they don't tend to do that. They tend to rely on airy statements about, we believe it's better to have care in the community than in hospital. Where? What are the outcomes? Where have you tried this? Well, it's never there. So yeah, I did read the business case. I found it flawed, and I found an egregious lie, and they refused to accept that they'd actually overstated the case. I do think home birth should be an option. My child was born in the middle of nowhere, so I know it can work. It shouldn't be a medical condition, but they do need to have access to obstetrics, and having one in the next borough is not good enough. I think to have the possibility that no child will be born in Ealing ever again, other than children born at home or in toilets of pubs to desperate teenagers, then is not the situation which I would call a healthier future.
Can you remember out of those thousands of pages, roughly how many you would think were actually discussing proposals for community-based services to replace the hospitals?
Oh, if I was to be glib, I'd say 3 or 4. Not very many. I don't think there's anything in there that suggests what the nature of out-of-hospital services would be 5 years after they wrote that plan. Because I don't think they knew, I don't think they had any idea of either that or how much money they would spend on it. But I think they picked a number that seemed reasonable, and they said there would be a number of programs, but I have no idea. I really do not know, and I don't think they know, what kind of out-of-hospital care provision they are going to put in place to replace the services of 4 A&Es, which are all the 4 central ones in their area.
So why do you think it is that people who obviously have some record of involvement in their own local health services and so on, Dr. Mark Spencer's a local GP and so on, why do you think people would be pressing ahead with a policy on such a flawed foundation?
I call it the Georgie Porgy syndrome. So they can sit in the corner and say, what a good boy am I, I've saved £1 billion for Mr. Hunt.
But will they save £1 billion?
I don't think so. Of course they won't. It's just specious mathematics that they like to indulge in. There is no way that they will save £1 billion out of the health economy unless they want to do it in a way that reduces the services to people and increases the risk to patients even more than they have done already. They cannot take £1 billion out of a health economy in North West London and not suffer appalling consequences.
I'm afraid you might feel my comment is question is frivolous, and perhaps you've already answered it, but it's really to extend the Georgie Porgy syndrome. I'm trying to understand why we've got this juggernaut moving and it's impossible to stop. Because like Dr. Lister, I know many of these people to be hard-working, sincere, good people. And I think perhaps maybe I'm not taking the Commission down a byway. Maybe it is important for us to understand their thinking. And I think you're the first person most closest to them. I mean, is it a matter that it's like a group cognitive dissonance?
Yes.
Oh, it is.
Yes, it is. The people that put together Shaping a Healthy Future are the people who've been running health services in North West London for 10 years. They then said, this is appalling. Look at those two hospitals, they're unsafe. Look at those two hospitals, they're unnecessary. But we have the answer. Now, to me, that's rather like the German submarine rescuing you from the ship that you've just been torpedoed in. That they come along and say, we've been running this for all these years, it's a mess, but we know how to get you out of it. I don't think that they come at it from the right angle. I think they are probably burdened by their past. I think they are not aware of the problems that they've created. And what they're looking at is a problem that they think somebody else has created and they can do something better for it. And I don't think they can, not by taking the easy option, which is chop out some hospitals, save some money, but you don't save a lot of money by chopping out A&E. You only save money by chopping out other things as well. A&E represents 2.65%, I think, of the London NHS budget. So it's a very small amount of the total money spent on the NHS in London. So taking out A&E doesn't help you very much, especially when it's only 4/9 of it. But it does help if you can then take out paediatrics and general surgery and all the other ancillary services. And then, particularly, if you can knock down a hospital and sell it for flats to investors from Dubai and put up a shed with some diagnostics in it and call it an emergency centre, which is the latest I've heard for the Ealing site. It's not going to be an A&E. Dr. Spencer said in an interview a couple of months ago to be an emergency centre, but not an A&E, no blue lights. But I don't know what it's going to be. Nobody knows what is going to be on the Ealing site. I challenge anyone to tell me what will be on the Ealing site in 4 years' time.
Can I push this just a little bit further then? I suppose my real question is, who are the decision makers here? Because every time you confront them with an untruth or an inconsistency or something that's not congruent, you get, and we've heard earlier, I'm advised that, I am told that. Who are the decision makers in the hierarchy? I mean, does it go all up the way? Is it Mr. Hunt that's directing things? Who is saying this has got to happen?
Well, the decision-making authority appears still to be an entity known as Shaping a Healthier Future. Because I keep being told that this has to be done because Shaping a Healthier Future says so. And I don't know what Shaping a Healthy Future is. I know that some of its people involve Dr. Anne Rainsbury, Dr. Mark Spencer, and somewhere along the line this nexus of clinical commissioning groups who all signed up to the original decision maker. They all signed up to the pre-consultation business case.
Oh, so it has the feelings of a cult then. So who's the cult leader?
Well, most of us would probably say Mark Spencer is at least John the Baptist.
No. I don't think so. But
yeah, it is a cult. It is Shaping a Healthier Future is, in my book, 2 documents that came out, put together largely by McKinsey's at a cost of nearly £4 million that we know about. And in fact, in the year 2011-12, they were being paid exactly £7,000 a day for whatever it is that they did for Shaping a Healthy Future. So they put the document together, along with the nodding dogs of the CCGs and the medical directors of the hospitals, one of which I am told did not know what he was signing when he signed up to the letter which said, I, as medical director of this hospital, agree with Shaping a Healthy Future. The CCGs, we know that the Ealing CCG was told at a meeting which Mark Spencer presented to, that at the end of the meeting the chair will be required to sign a letter of agreement to Shaping a Healthy Future, and that's in the minutes. So the CCGs were told, you sign up to this, the medical directors were told, you sign up to this, so they could then say, we have clinical agreement for Shaping a Healthy Future, because a load of people had signed exactly the same letter. Precisely the same letter, with one exception. I forget which one of the CGs it was that said, provided suitable provision is in place right at the end. Otherwise, the paragraph's exactly the same. So they all signed a round-robin letter. I don't mind that if it was presented that way, but it wasn't. It was, they all, as it were, individually said how wonderful it was. So this thing called Shaping a Healthy Future is what's driving the process, and it is an assembly of various bodies, some now defunct, like NHS North West London, some now more or less alive, not quite sure, CCGs. Dr. Mark Spencer is a continuing thread, as is Dr. Rainsbury, and various people pop in and out from the clinical profession and utter things, and various administrators pop in and out, and Mr. David McVitie, who calls himself a recovering accountant, who now runs London North West Healthcare Trust, is off at the end of this month, so he's popping in and out. So don't ask me who's running it, it's called Shaping a Healthy Future, and that calls the tune.
Thank you.
One last question. Do you have a figure attributable to the current running total of costs for consultancy in relation to this exercise?
I would have to do another FOI. I don't. I forbear to ask because I know it would frighten me.
Would you ask? Please.
I shall do that.
Yeah.
I could provide the information because or from the first point.
If you can speak to Martin, thank you very much.